This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 7, Cardiac Resuscitation. Key concepts. Upon completion of this chapter, you will understand 4 identifiable factors that lead to cardiac arrest, why resuscitation is only given to those with a reasonable expectation of survival, importance of finding and honoring a valid patient DNR order, and the way teamwork is essential to perform a well-conducted resuscitation. Chief concerns on this. Patient appears to be in cardiac arrest. You generally have unknown medical history with this. Try to obtain medical history and see which ones that are pertinent to what might be going on. Acute coronary syndrome might be suspected. Maintain an open mind. We're going to learn here in a second several acronyms for putting the H's and T's in our head. So the paramedic may find a readily correctable condition or a treatable cause and get spontaneous circulation quite rapidly. Factors leading to cardiac arrest. Identifiable factors. Decrease the preload and you're going to decrease cardiac output. Very simply, if I decrease the amount of blood coming into the right side, then my output is also going to be decreased. Things like hypovolemia, inadequate pump, right-sided failure, all could decrease, or right-sided failure would actually increase the amount of preload. You could cause congestion, but decreased preload, identifiable factor in cardiac arrest. Decreased myocardial contractility. The heart itself can no longer pump efficiently for whatever the reason. Errors of automaticity, and in those errors we see the dysrhythmias. So if they're bradycardic, tachycardic, NV-tach, NV-fib, things like that, you can have no cardiac output or very little cardiac output. Hyperkalemia is another cause. Sodium-potassium pump is required to generate an action potential in the actual cardiac muscle cells. So if you have too much potassium on the outside, it's going to throw a monkey wrench into the sodium-potassium pump, or the ability of the heart to generate an action potential. And then cardiotoxic medications. Things like beta blockers, calcium channel blockers, all are high on our list. Digoxin would be too. Or an increased afterload. If there's too much pressure in the vessels, and the heart's having to work too hard against that, eventually we're going to go into failure. So acute coronary ischemia, electrolyte imbalances like hyperkalemia, renal disease, Addison's disease, diabetic ketoacidosis, low magnesium levels. The number one cause of polymorphic V-tach is low magnesium levels. That's why we give magnesium as an antidysrhythmic. Hypocalcemia, low calcium levels, don't have the ability to originate the beat to begin with. Cardiotoxic medications, tricyclic antidepressants, beta adrenergic blockers or beta blockers, or calcium channel blockers are all cardiac toxic. If you get a toxic level in the system, it will cause cardiac effects. Tricyclics increase QT interval, which will widen out your QRS. Beta blockers decrease contractile force strength and the rates, so the person could have a heart rate of 20 and it wasn't contracting appropriately. Calcium channel blockers make you hypotensive from dilation of the vessels, and then it will slow down the rate as well at the AV node and at the SA node as well. So calcium channel blockers, calcium channel is what initiates and makes your contractions more effective in the middle of your cardiac cycle. Cardiac mnemonics, and these are a bunch of different mnemonics to remember. Essentially, what they're going for here is the H's and T's. I like this one probably the best, or I teach my students one, Chet 4H DOA. The CHET would be a mechanical problem. 4-HDOA would be an electrophysiological problem. And I'll go to the board and show that in just a second or two. But hypoxia, hypovolemia, hypothermia, hypokalemia, hydrogen ion excess, tablets or toxins, tamponade, cardiac, tension pneumothorax, thrombosis, pulmonary, or coronary, and then trauma. Now, the one that I teach them is CHET 4-HDOA. So cardiac, all of these are mechanical cause. Cardiac tamponade, hypovolemia, embolism, and tension pneumothorax. Please go over the algorithm slides and videos, and they'll explain this out in detail. Oop, I already had an H. So this is the 4-HDOA here. Again, these are in the algorithms. They're gone over explicitly in PEA and systole. But cardiac mnemonics help you remember what might have caused the patient into getting into full arrest. An algorithmic approach. Establish whatever condition got them there, or trying to, the antecedent condition. Determine whether or not your patient actually has a realistic chance of survival. If there's obvious signs of death, then they probably don't have a real chance of survival. Clinical signs of death, unresponsive apnea and pulseless. And do not attempt resuscitation if the patient has a DNR or any other executed document. An example of this would be like a living will. Be sure that they don't have documentation that they don't want to be resuscitated. These are signs of obvious death: mortal wounds, decapitation, incineration, decomposition, or decomp, massive head injury. Traditional signs of death would be rigor mortis, algor mortis, or liver mortis. Rigor mortis is stiffening of the limbs, occurs in humans at about 3 to 4 hours and reaches its maximum stiffness at about 12. Algor mortis is a reduction in the body temperature following death. That's kind of hard for us to assess, but if they have rigor, that one's generally pretty easy for us to pick up on. And then liver mortis, settling of the blood in the lower dependent portions of the body, so they're a bloodline essentially. Cardiopulmonary resuscitation in progress. Important points: determine CPR technique and adequacy, and the CPR compression rate and depth. Just make a quick assessment if you already have CPR in progress, how well the chest compressions are doing. Are they giving us a good perfusion pulse? And if not, let's coach the person a little bit so that we can get a good cardiopulmonary or CPR out of this. Ventilation with a bag mask assembly. Under BLS, our initial settings, a 30 to 2 process, 30 chest compressions with 2 ventilations. Establish scene information. Try to get as much information on the patient, what time they collapsed, when were they last seen, that kind of stuff. Any kind of medical history or allergies that we should be concerned with. And determine the rhythm. If it's already in chest compression process, figure out how far into those chest compressions they actually are. So if they're a minute into them, they can go another minute of chest compressions there before you, in that time, hook up your cardiac monitor so that you can assess the rhythm for the first time. Teamwork in resuscitation. Effective defibrillation is the key to successful ventricular fibrillation resuscitation. The results of an effective defib are going to be a systole. That's what you're asking the heart to do, is to restart itself and depolarize all at the same time whenever you hit them with the electricity. If that works, they should pop right into a systole. Leadership and teamwork. Team quickly coalesces into a functional unit. Consider calling for any additional responders that you need at this point, and consider contacting medical control early, especially if you want to get off your standardized protocol. As far as teamwork, it's a team effort of integration. There should be a team leader. The team leader should remain focused on basic life support and maintaining basic life support throughout this, even at the point that they switch to ALS. Delegation of specific items to be facilitated. Several roles must be fulfilled in this. We need generally someone documenting. We need somebody that is running the monitor. That person could be the same person if, depending on the technology in your monitor. Most of the newer LifePack series have something called an event scroll push, which time codes specific interventions. Communicates clearly. A hands-off approach if possible. You should delegate this stuff, and it allows that person to have a global assessment. Interprets and announces the rhythm, and that gives people signposts. So currently showing a systole in the monitor. Let's get back on the chest. An example of that. So everyone knows that we need to have CPR continuing in this, and that the patient had a systole on the monitor on that last assessment. And debriefings. Review care provided at the end of the resuscitation, whether it was positive or negative resuscitation. Basic life support and cardiac arrest include airway, breathing, and circulations. We do this in the form of CAB. We have an unresponsive individual that we don't see them moving around and breathing. We check for a quick pulse and get on the chest compressions. We do it chest compressions, airway, and breathing, and new HA. Be sure that the airway remains open. Be sure that breathing is occurring. 30 to 2 in BLS mode. Circulations. Be sure if you're using cardiopulmonary assistant devices, like say circumferential chest bands or piston pumps, be sure that those are adequately providing good CPR. And then when should defibrillation come into this? Considerations of this is at the 2-minute cycles, we have a stop or a lull for a 10-second break. Assess what the rhythm is. Determine which direction, if you're going to shock or not. A good thing to do in that is to charge the paddles ahead of time in anticipation of a shockable rhythm. So charge the paddles to whatever setting you have, and that would be either biphasic or monophasic. And have the paddles ready. Have them all hooked up. Have them ready to go or deliver the shock. So you charge paddles and it's waiting there. At the end of this 2-minute cycle, you stop CPR. Showing currently ventricular fibrillation on the monitor. I'm clear, you're clear, we're all clear. Deliver the defibrillation and continue chest compressions. Advanced life support modalities. Whenever we bridge to an ALS or an advanced life support mode, we need to provide intubation and IV access, and then we're going to administer medications. Airway devices should be endotracheal tube placement. If you cannot verify the endotracheal tube by other means, then maybe you should go down to a supraglottic airway. Even a basic airway is functional if you can control the airway. Advanced airway devices like an endotracheal tube, there are alternates to those advanced devices like a King or a combi tube. Faster placement on the King or combi tube, less disruption of chest compressions, and chest compressions are very high on our efficacy list. Circulation access, obtained to administer antidysrhythmic medications, so an IV or an IO access. Cardiac arrest medications, The mnemonic navel is utilized so in case we don't generally go down the tube anymore, because we have things like the IO needle to where we can get to central circulation quite rapidly. But navel was a mnemonic that would go down the tube. So Narcan, atropine, vasopressin, epinephrine, and lidocaine may be administered via the ET tube. Now, it is not the best medicine to do that. If you have the ability to drop an IO, then drop the IO and deliver the medications to the central circulation. Advanced cardiac life support drugs, vasopressors. Those are the first medications in any pulseless arrest, things like vasopressin and epinephrine. They make things beat harder, faster, stronger. And the next class of that are generally administered is an antidysrhythmic. Top one on the list currently for wide complex, whether this be VTAC or VFib, is going to be amiodarone. And then consider other possibilities if the patient's unresponsive to resuscitative efforts. Maybe you haven't thought of enough stuff, so go through the H's and T's or the causative factors that might have got him here to begin with, and reassess if you're delivering what the patient needs. Evaluation. Successful defibrillation results in a brief period of asystole. In asystole considerations, ensure that the patient is asystolic. The medication that we would be given in asystole is going to be epinephrine. Again, take a look through the algorithms. Each one of them are broken down individually. Pulseless electrical activity, a catch-all term for a number of rhythms. It's essentially anything that shows electrical activity on the monitor but does not generate a pulse. And the goal on this is to actually create a pulse. Sequence treatment on this is going to be epinephrine every 3 to 5 minutes, and then correct the underlying cause that got him there in PEA. As far as disposition goes, main therapeutic goal of resuscitation is going to be spontaneous circulation, establishment of cerebral and coronary perfusion pressure. So we want to maintain cardiac output, maintain perfusion to the brain, and restore circulation is our goals here. Important concerns: evidence of perfusing rhythm, maintaining spontaneous circulation, and then an assessment of what got us here, what can we get ahead of, and what can we stabilize and take them to the appropriate facility. In ROSC medicine, or return of spontaneous circulation, or post-arrest medicine, we generally try to provide therapeutic hypothermia. And what it does is it allows an improved neurological outcome. So by cooling things down, especially if they've been anoxic for a while or under low perfusion states like CPR, it improves their neurological outcome, so there's not near the neurodeficit once we get things going again. Risks on this: their risks is that we can cause dysrhythmias or we can cause coagulopathy. Procedure to do this would be ice packs in any place where there would be a pulse point, neck, groin, and infuse 30 milliliters per kilogram of cold saline, about 4 degrees Celsius, over 30 minutes. Any kind of termination of resuscitative efforts in the field, and this was pretty much pioneered due to the dangers of transported hopeless cases, hazards not only to the citizens but also to the medics themselves. And it's pretty much supported by medical literature. Requirements on this are pretty broad, and they would depend on your local protocol. Patients must be asystolic, or in a pulseless electrical activity at a rate less than 60 beats per minute. A trial of advanced cardiac life support must have been unsuccessful, and typically includes CPR with defibrillation, ALS, treatment modalities, and so on. At most places, most locations, you'll need to call a doctor to confirm termination of the resuscitation. Termination in the field, thought to reduce patients transported to the hospital, especially whenever there's not a lot of hope. Various services have specific protocols, so please look at your local protocols for the stopping of resuscitation. Notification: decision to terminate resuscitation, accompanied by the need to notify the family. Predicated on 3 factors here. What does the family want? the ability to provide grief counseling, and conditions needed to terminate the resuscitation. This would be by protocol. Mnemonic is grieving, to remember the things that you actually need in play. Procedure, there needs to be in appropriate locations, arranged to have chairs available so that they can all sit, and you can kind of talk about it. Gathering of the family, resources such as fire services, clergy, identifying by name, title, and position, emergency services that are present, verifying the family's understanding, giving the family members a little peace inquiry if there are any questions, the nuts and bolts of it, the process of viewing the body, and give the family a telephone number or contact information that they can get a hold of people at. That's the notification process. Most normally, police take care of this. In most forms and fashion, do the notification. But occasionally you will find some EMS services that need to pick up this due to low availability of law enforcement in their area. So, in conclusion, cardiac resuscitation may seem mundane, provides a unique opportunity for critical thinking and problem solving. References for this chapter were taken from Myers Professional Paramedic, Volume 2, Medical Emergencies, Maternal Health and Pediatrics of Delmar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.